Welcome and good afternoon to the many of you from our community who are joining us today for a panel discussion on cancer care during COVID-19. I'm Dr. Chris Holmes. I'm the current co-director of the University of Vermont Center and division chief of Hematology and Oncology. And on behalf of my partner, co-director, Dr. Richard Galbraith, as well as the entirety of the University of Vermont Cancer Center community, I'd really like to welcome you as we launch our first presentation of the 2020 Women's Health and Cancer Conference webinar series. While every day we're focused on delivering compassionate and cutting-edge care and working to advance cancer prevention and treatment through all of the research here at the Cancer Center, our annual Women's Health and Cancer Conference, and now this webinar series, is a critically important piece of our commitment to our community education and patient support. Tremendous panel today. I'm just going to briefly introduce them. Our moderator is Dr. Jim Wallace. He is the current medical director of the radiation oncology at the University of Vermont Cancer Center, as well as associate professor in radiation oncology at UVM. Again, he'll be our moderator, and I want to thank you, Jim, in particular, for taking on this role. Also on our panel today is Dr. Timothy Leahy. He is a current UVM professor of medicine and director of medical ethics at the University of Vermont Medical Center. He also is an infectious disease specialist. We also have Dr. Michelle Soden joining us today. She is an associate professor in the Department of Surgery and is the current clinical director of surgical oncology at the UVM Cancer Center. And finally, we have Dr. Diego Adrianson. He is currently an assistant professor at the University of Vermont, and in addition is a medical oncologist at the University of Vermont Cancer Center. So I want to thank everyone on the panel. Obviously, I'd like to thank everyone for joining us. I'll turn it over now to Dr. Wallace, who will take care of some of our housekeeping issues first and provide a little guidance for the panel. So thank you again for joining us. We really hope to see you again for future presentations and programming at the University of Vermont Cancer Center. Jim?
Thanks, Chris. It's great to be here and start off our new era of the Cancer Center and reaching out to the community and try to do one of the things that we're tasked to do, which is to share our understanding as best as it is about cancer with people who are interested. We, at the very beginning, when we sent out information about this, we asked people to submit questions. I think all the panelists have seen those questions and have tried to integrate some of those answers into their presentation. But we will definitely be looking to answer those that we didn't answer at the end of the presentation. And if anybody would like to use the chat function within Zoom, feel free to, and we'll try to do our best to get to the questions as best we can. And then finally, just a disclaimer. We are going to be talking about COVID and cancer in a very general sense. The questions might get a little bit more specific than that, but we just have to make sure that everybody understands that we really encourage everyone, if you've got any questions about your specific condition or concerns, to really get individualized feedback and guidance from the people that are caring for you or your family or others. So with that being said, let me hand it over to Dr. Tim Leahy to kick us off. Thanks, Tim.
Thank you, Jim. I'm delighted to join the panel today, and we'll start us off with about 8 minutes of context about COVID-19 and cancer, making sure that everybody's on the same page about some of the bigger patterns we're seeing. And then, of course, in the Q&A, we can talk about more as you see fit. So as of today, there are about 9.4 million cases of COVID-19 recorded so far, leading to 482,000 deaths. The United States is competing for #1 for the most affected country in the world, with about 2.4 million of those cases and 120,000 of those deaths. Vermont has been less intensively affected than many states and has a better looking epidemic curve, but we still have many stories of woe. We've had just shy of 1,200 COVID-19 cases and more than 56 deaths. One of the remarkable differences between COVID-19 and other global pandemics is that it is not confined to a particular geographic area. There's not one particular demographic group that's vulnerable to it. And none of us, let's be honest, feel completely safe from it. But we've known from the very earliest days that there is particular risk to COVID-19, that young people in particular who have no medical conditions may or may not even know they're infected, or if they do, they tend to have a milder case. Whereas if there is medical fragility or social fragility in the form of poverty or malnutrition and other social determinants of health, the severity of COVID can be much greater and mortality rates can be higher. And this early on led all of us to wonder, is cancer a risk factor for severe COVID-19? We knew that older age, medical fragility such as severe diabetes or lung disease were problems, and we wondered about cancer. And it turns out that the story with COVID-19 and cancer is a bit more nuanced. It turns out that we believe that people with cancer, like other medical problems, do have more risk from COVID-19 than if they didn't have cancer. The best study published last month in the Lancet suggested that among people with COVID-19, those who had active cancer had a 5-fold greater odds of mortality in the first month. So cancer and COVID-19 is a scary combination. That same study and some other studies along with it made a very important other observation that I think is incredibly important if you're a patient seeking cancer care or somebody who loves a patient seeking cancer care, which I think means all of us on this webinar. And that is that cancer patients who were getting therapy for cancer did not have higher risks of death from COVID-19 compared to other cancer patients who had COVID-19 but were not getting therapy. It didn't appear that getting treatment made them at any higher risk of severe outcomes from COVID-19. I think that that's a complicated relationship, and we could unpack in the Q&A what that could mean for different sorts of cancer therapy, people with different sorts of cancer. But I think the overall take-home message there is that uncontrolled, untreated active cancer can make you vulnerable to various things, including COVID-19. But the treatment itself doesn't add to that risk, perhaps because it helps control the cancer. One of the natural questions when you're thinking about how to stay safe from COVID-19 is, particularly if you know that you have special vulnerability, is how safe am I coming in to get my health care? I think all of us wondered whether hospitals and clinics could be hotspots of COVID-19 outbreaks, and early on they were. All of us remember nursing home and hospital outbreaks in the early days of the pandemic. What's incredibly important to know is that we have learned so much during the past several months, most particularly about how to stay safe and to deliver medical care safely. And so when I walk into the hospital every day, I actually palpably feel my blood pressure drop. I'm greeted by a nice person at the door who asks me how I'm doing, gestures to a list of symptoms and asks me if I'm having them. They take my temperature and they give me a new mask. And as I walk into the building, I trust that unlike the grocery store or the place where you go get takeout, 100% of the people are wearing a mask. Everybody's washing their hands. There are special procedures underway or in effect, at every location to make sure that it's not crowded. And I genuinely view UVM Medical Center and our other healthcare facilities as the safest place in town. So I have no misgivings about any of my patients coming in to get care, and I have no misgivings about coming in to get the care that I need. So the danger I do worry about, and I have talked with my colleagues in oncology about this, are cancer patients who worry about their vulnerability to COVID and stay away from medical care for fear of being around somebody else who has it. And I worry about the risks of that. I worry about the risks of them not getting the cancer therapy that they need and having progression of their cancer. That progression of cancer, to me, is the thing that leads to the greater risk of COVID-19. And so I think one of the bigger take-home messages is now in June of 2020, we've got a read on how to be safe, how to deliver care safely, and I want people to know they can trust that. And so I'll close with hope. In the last several months, we've learned more even than just about how to stay safe. We have 2 drugs that appear to treat bad COVID-19 and make it a little bit less of a fearsome thing. We have dozens and dozens of vaccine candidates in the works, being studied, advancing in stage trials in hopes that we'll have a way to stay safe from this in the future. And we are learning all the time how to get this right. And I think most importantly, we've seen incredible community efforts from the healthcare community, your nurses and your doctors and your others, but your neighbors and you are all pulling together to make this right. And so I think this is a time we're going to look back on and say, yeah, it was a fearful time, but I think also it's going to be a proud time that we're glad to have risen to this huge challenge. So Jim, I'll turn it back to you and happy to take questions in the Q&A.
Thanks, Tim. So we're going to try in this technological world to transition who drives the slides. And if not, I might just ask Jackie to advance the slides. Jackie, I'll have you go to the next slide. Thank you. So whenever we're tasked to pull one of these things together for learning, we're asked to pull some objectives together, and I think it's a good exercise, useful exercise, at least so everybody in the audience has an idea of what we're trying to do. And as I thought about it, I thought, well, what did we have to do? What are we doing now? And what do we expect the impact of COVID-19 on cancer care to be in the future? So those are really the objectives, and I hope people get to take some of that away from us from our time today. Go to the next slide. So as I thought about the few minutes I'm going to spend about this, I thought about it in a little bit of a story. That's frequently how I talk to patients, is trying to put these in a story. And there were a number of themes or chapters to this story that came to me as I did this. And this kind of happened chronologically. And we're going to look at some of these slides chronologically, or how we dealt with this chronologically. And these are the basic topics that I think were really important to us early, and now becoming something that are going to be with us forever. We'll go to the next slide. So a huge part of cancer care, and one of the reasons why I wanted to take care of people with cancer, was the fact that it is very much a team that does this. So we have a team in radiation oncology with physicians, nurses, therapists, social workers, and that team by default always got together every single day. And the team across our disciplines, across medical oncology, hematology, surgery, got together at least weekly to talk about our patients, particularly the complex patients. And that, the slide furthest, or the picture furthest to the left, was on Wednesday, March 18th, and we had just been told that those meetings, we call them tumor boards, were not going to happen in person any longer, and we were struggling to figure out how to do that. So this is a group of our nurse navigators, our nurses who help steer our patients in the right direction as they go through their initial diagnosis, sitting in our conference room, and we see how different things are even now compared to then. Learning how to use Zoom, that's what that was all about. So not all that long ago. The phone that we had in that conference room up until about a week before this was just a regular wall phone, certainly not enough for the purposes that we now use routinely. And on the right is the first meeting that we had as a department the third week in March, where we were doing our best to be physically distanced, but this was before masks were recommended, and very, very different than us crowding into that same conference room just a week earlier. So at first, frankly, our biggest worry was, how can we take care of patients if we don't get together and talk about them? And to be honest, I think we've done a decent job with that. We'll go to the next slide. So how do we do that? Well, on the left, I try to represent how we do these tumor boards in these meetings. And without sharing specific patient information, I couldn't come up with a way to do that very easily. So I just took this off the internet. But we had a tumor board just this morning, and there were about 22 of us, pathologists, radiation oncology doctors, medical oncologists, surgeons, radiologists, and we reviewed the patient, their presentation, and appropriate treatment. And to be fair, it actually works quite well. And the exciting part of it is our colleagues now within the network in Plattsburgh, at Central Vermont Medical Center, and Alice Hyde, now the barrier to them joining that conversation is significantly less. So we're doing a better job communicating across our network and to others about the best care for our patients. So this is something that we learned about, and we're going to continue to leverage moving forward. While we're talking about Zoom, I just want to take a minute to talk about how we manage this from a patient-to-patient, patient-to-provider perspective. And it actually goes pretty darn well now. I'm going to be interested to see how this goes in the longer term. But come March 21st or so, we basically stopped seeing patients. We're going to take a look at some of that data in a minute. Stopped seeing patients in the clinic. And it took us a while to figure out a way around that, an alternative. And I think Zoom has provided us a nice way to do so. The question that I have, maybe for people that are attending today, and you can send me a message in the Q&A function or otherwise, is if Zoom is better than no visit, is Zoom better than an in-person visit? Because until we sort this disease out and until we can worry less about physical distancing, we simply don't have space in this building. I'm at the medical center to get as many patients in the building as we had before. So we're gonna have to find other ways to take care of the same number of patients. You can go to the next slide. So this is something that I thought was kind of interesting, and it'll just take me a minute to walk through. So the purple line represents the total number of patient visits that come to the University of Vermont Medical Group faculty practice. So those are doctors that are associated with taking care of patients here in the Burlington area. So the purple line is just total number of visits, and we have typically averaged 50 to 60,000 visits per month. And then blue are the number of in-person visits. And as you can see, up until really February, that was it exclusively. In February, I have the actual raw data, and I think we did 29 video visits in the month of February because some providers just found it useful for one reason or another. That's, we were typically calling this telehealth. Well, March, things changed considerably. Obviously, the clinic shut down in mid-March. And the telephone visits in green now, the green bars, became more popular because they were quick and easy. I want to emphasize, though, lots of us call lots of patients on the phone just to chat with them. These are scheduled telephone visits. So while our total number of visits were down, I talked to more patients in the month of March than I probably ever did, but they were just quick visits. We don't have the time or the expertise to figure out how to do this visit right now, but we'll figure it out very soon. And then the red bar, the video visits. So in February, the number was 29. And if we get to May, the number is 18,000. So from February to May, we went from basically doing 0 to 18,000 monthly visits with Zoom, and I expect those numbers to continue to rise. I think appropriately there will be some balance between video and in-person visits, and the telephone visits I think will be less and less common because I did a telephone visit with a patient earlier today, and it is more difficult if you can't see their face, understand their body language, and vice versa, they can't see yours. We'll go to the next slide. So we can't meet in groups. We figured that one out. How do we try to keep sick people from us making other people sick? How do we make sure that we don't get sick? And Tim alluded a couple minutes ago to the practice coming into the department and to the hospital, making sure we're safe. The picture on the left was on March 21st. We all kind of knew how to put on our protective gear, but I had to evaluate a patient who came to our office with a fever that very day. This was back when we were not screening routinely at the door, but at our own doorway, clinic doorway. And I had to put the face shield on, as you see in the middle, put all this material we now all call and familiar with PPE. And the first few times, frankly, it was a bit stressful, and I forgot. I did it wrong, to be honest. The first time, I had to go back and see the patient a couple minutes later to do another evaluation after talking to the emergency department. And I had somebody literally watch me put the stuff on and watch me take the stuff off, and I did a much better job. But it's teamwork and it's equipment. And nothing smells sweeter to me now than a treatment room that smells of Clorox. And that's pretty much what this place smells like now. We can go to the next slide. So if somebody is asymptomatic but comes to our department, how can we make sure that they don't make fellow patients sick or make us sick and then subsequently infect patients that we subsequently see. So we have a beautiful waiting room. I hope most people never have to see the radiation oncology waiting room, but it is a nice one. But we did, in fact, tape off a number of chairs to make sure that we maintain 6-foot distance between patients. And remember, all patients are masked. And in every single room in our department now, and I assume throughout the hospital, there's well-known occupancy limits, which has implications for how many people can come in when we see patients. So we don't have family members with them, which is really a challenge sometimes when we're talking to patients with new diagnoses of cancer. But there are ways around that. We certainly have rooms where we can see more people in a room if we need to, or we have the patient with us and we've got their family members on Zoom or just on the phone. So we're working really hard to make sure we do this right. So we're safe, yet still provide good care. Go to the next slide. Just a couple other things, and then we'll move on. How to keep up. So again, Dr. Leahy was talking a minute ago about data in Lancet. It is really hard to keep up with the data. And it was very hard for me to get granular data about how much had been published specifically related to COVID and cancer in a short period of time since really the beginning of March. So I just looked at another place that keeps track of data very, very clearly. So Google keeps track of these trends very clearly. And I would say that the medical literature is following this trend, maybe a little bit behind this trend, but nonetheless, there has been an explosion of data of COVID related information, which is frankly overwhelming. I think many of us tried to keep up for the first week and then try to find other ways to do that. So this is for people, if you can't see it as clearly as you'd like, the red line are the number of Google searches related to coronavirus. And then the other lines you can probably see weather, news, music, and sports. So it took a big peak, and there has been a coincident big peak in publications about COVID and to a lesser extent, but still ongoing COVID and cancer specifically. Next slide, please. Yep, thanks. So just specifically things about radiation oncology, things that we pay attention to on the right side of the slide. The patients that come to us may be immunocompromised. Sometimes simply their disease makes them so. Sometimes our treatment makes them so. Unique things about them is that they come to our department every single day. And if they're asymptomatic, they have multiple opportunities to potentially make us ill. And we have multiple opportunities potentially to make them ill. So we have to be careful and mindful about that. And we've got some patients, because of the position and the immobilization techniques that we use, where they can't wear a face mask. And we need to come up with ways to make sure that we could be safe if they weren't making masks. And then under best practices and innovation, given the extent and the rapidity of how things moved in the literature, we are looking, frankly, at things like Twitter. Thankfully, I've got some colleagues of mine who are quite good at it. And frequently we find out the latest innovation through those things before certainly they get into the published literature. And then finally, to summarize from radiation oncology, the last slide. I think there's been a significant amount of discussion about how in radiation oncology we can do our care safer, keep our patients safe. And in reality, for us, that means delay treatment if people are ill. Certainly in March, we were delaying treatment to keep people from getting ill. And there's a big discussion about, can we decrease the number of trips patients have to make to our department to get treatment? And that will be a subject of ongoing research for probably the next 15 years, frankly, to figure out how to do radiation therapy more quickly. So I'll close with that and move over to Dr. Adrianson.
Okay, thank you. I'm glad to join, and I'm very happy we're doing this webinar. And I will try to present what have we done in hematology and oncology to adjust to COVID-19. I'm trying to see if I'm able to control. I don't think I'm able to control the slides. Oops. So if we go to the next slide, please. Okay. So first of all, I wanted to say, as echoing as what people have said before me, in the last few weeks, we basically have transformed healthcare delivery, and that includes how we care for patients with cancer. I think these 4 steps summarize what we adjusted to, did, and what the future will look like. First and foremost, we want to ensure that patients that need to continue their care can do so. And we want to make sure that they can do so safely or as safe as possible. That means that we have to get ready and prepare for a new routine that will include new ways of like adjusting to regular safety measures in the hospital, telehealth visits, video visits. And finally, we want to reinforce that we are here to support patients because, as everyone has alluded to before, this is new for everyone and it's scary to navigate through the, how to adjust to the new way of delivering healthcare, especially in patients who have a diagnosis of cancer. Next slide, please. So in hematology and oncology, we usually have groups of patients and not everyone is in the same category. As you may know, some patients might be in survivorship or surveillance, meaning that they were even treated with chemotherapy, surgery, and they are in remission from their cancer and they are just following with some scans or physical exams or regular blood testing, or they are on surveillance because they have an indolent cancer that does not need immediate treatment. So the first guidelines, before we had a lot of information about how the disease was going to go in each specific geographic site, was that for patients that can avoid exposure to the hospital or their clinician's office, they should do so. Because there was definitely a high risk of exposing yourself and getting infected. Now, as Dr. Leahy mentioned, we have done a very good job here in the state and our numbers are not so bad and the cases are relatively low compared to other places. However, we want to keep it that way and want to make sure that we are following still these recommendations. Some of these patients who are survivors or who have an indolent cancer that doesn't need immediate treatment may be at high risk of complications if they acquire COVID-19. So it definitely makes sense to, one, follow very strictly the public health recommendations issued by the CDC, and two, to prevent exposure as much as possible. Next slide, please. So the next group of patients we usually care about in our clinic is patients who are on low-risk treatments. They may be on a hormonal treatment, or they may not necessarily be getting a big surgery or radiation, but just maybe an oral therapy. For those patients who have these diseases, they are considered to have active cancer, and therefore the most important thing is to come up with a plan that you should make together with your doctor. We have very specific guidelines in all our different institutions and societies, including the American Society for Clinical Oncology and American Society for Hematology, have come up with guidelines to help us make these decisions, stratify the risk for each individual patient, and try to minimize their exposure as much as possible. So depending on your specific situation, you and your doctor should come up with a plan as to how frequently to do telemedicine visits, what can be delayed, what cannot be delayed, how to adjust, where you should get some testing if you were coming to the main hospital to do imaging or laboratory, if you could do it in a smaller place closer to home and minimize your exposure to the main hospital. All of those details will be discussed. And it's very important to do so even if you are on treatment with this low, what we would consider otherwise low risk therapies. There are mechanisms in place for patients to have their oral treatments and give refills that may last longer in case for some of the medications that before we could only prescribe for a month. And so all of these adjustments are being done. But the summary is that it's one case at a time and every patient is different. So the most important thing is to come up with an individual plan. Next slide, please. So obviously, for patients who have cancer diagnosis, a lot of that, those telemedicine visits or delay in treatment might not be an option. And we understand that, and we are ready to treat and keep all essential appointments for every patient that needs it. The most important thing that we want people to know is that we are doing all the special measures that are recommended, and we have put in place specific guidelines to protect our patients and our staff. So as someone was mentioning before, you'll be greeted at the door, you'll be asked to wear a mask, you'll be screened in terms of asking for symptoms and checking your temperature. In addition, you may be contacted via telephone the day before your scheduled appointment to check that you have not developed any symptoms that might be concerning. And if you do report any symptoms, you might not be permitted to attend the hospital, but rather be directed to an adequate place where you can be tested. Next slide, please. In terms of the direct cancer care that cannot be done remotely, that includes different aspects as their radiation, chemotherapy, surgery, immunotherapy. Now, we know that a lot of these treatments are immunosuppressive and may reduce your risk of your ability to fight infections. However, as Dr. Leahy mentioned before, we now have data that chemotherapy and cancer treatment itself is not necessarily a high risk factor for worse outcomes if you do acquire COVID. The most important thing, as with patients who were on the lower risk therapies, is to talk to your doctor and come up with an individual plan. Some treatment delays, some omission of certain cycles of therapy may be warranted and may be safe to do in some patients, even if they are getting chemotherapy. So it's very hard to make generalized recommendation because every patient is different. And we are ready to, you and your provider, we are all ready to come up with plans for each specific patient. Next slide, please. I wanted to make sure for everyone in the community to know that urgent cancer care is not delayed and was not delayed either at the peak of when the hospital really was, struggling with adjusting to this new reality. Patients who require emergent treatment, sort of very aggressive cancers that have a high risk of mortality in only a few weeks, like leukemias and things like that. We always continue here at the University of Vermont, and since then we've gotten even better at adjusting and being able to do this safely. So I included that there was a poll recently, and this is UK data, but patients were almost as concerned about contracting the virus as being turned away from medical care. So right now, in terms of our cancer center, we are ready, we have adjusted, and we want to make sure that everyone knows we are not delaying any urgent cancer care needed for any of our patients. Next slide, please. And that includes our chemotherapy and treatment units. So the decision that you come up with your provider may be that, yes, in your case, it's very important to keep you on schedule to continue your therapy because you can have significant complications if you stop and it's not safe to do so. When those decisions are made, and as I said before, they're made together between patients and their providers, our infusion therapy units, our waiting rooms, everyone has adjusted in terms to keep social distancing, to minimize the number of patients that are next to you, the spaces that are shared. For example, in terms of blood draws, now there's not a line outside our waiting area. Every patient has a plan well in advance to either go to a previous lab or to come individually to our clinic. So, and our nurses have done a fantastic job in terms of keeping up to date with all the recommendations and pre-screening calls and COVID testing for our patients. Next slide. Finally, what to do if you do develop symptoms, which you may be concerned there are COVID. The most important thing to do is call us and ask for guidance. Although it's good to keep up the recommendations that public health institutions are putting up for everyone, there is a concern that cancer patients are a different population. They might be more vulnerable, and so we have specific protocols and specific resources that we can help you with. Even if you need COVID testing, probably the best thing that you can do is contact our office, contact your primary oncologist or radiation oncologist, hematologist, or any provider, and ask for guidance in terms of where to get tested, when, and how to get tested. Next slide, please. And finally, I guess someone mentioned that before. Initially, because a lot of centers in more hard-hit areas were closed and a lot of care was delayed, we are seeing the missed effect of the pandemic, which is some cancer diagnoses were missed or expected to be missed this year compared to previous year in terms of patients who did not have on-time screening, testing, or radiology imaging. So know that if you are at risk or if you have a cancer diagnosis, we understand that this fear is real and that we are seeing a significant impact, specifically in hard-hit areas. So next line, please. Here at the University of Vermont Cancer Center, we are here for you and we're here to guide you. Next slide. And I just wanted to share that there are a lot of patient resources out there, and sometimes a little bit overwhelming, even for us, as Dr. Wallace was saying. Even for us, it has been hard because there's just a lot of papers coming out at the same time and a ton of new information. So it's the same for patients and their loved ones. So if you go to our website, there is a selected number of resources that we believe are good and have been checked to be very accurate. And so with that, I think I will pass it along to Dr. Snowden.
Well, I'm going to start out by saying, hi, Mom. She's in Florida watching. And it's always fun when your mom gets to watch you do your job. So I am one of the surgical oncologists at University of Vermont, and I have a specialty in breast surgery. So a lot of what I'm going to be talking about will be in the context of breast treatment. But in an effort to get prepared for this webinar, I talked with several surgeons in the facility that treat other types of cancer, and it seems like the breast team was sort of mimicking and doing the same thing that the rest of the teams were doing. So I think what I'm saying would be applicable across all the disease types. Next slide. So I say my two hats and how I wore them like it's past tense, but the reality is that in academic medicine, we all wear a lot of hats. My biggest hat, the one that I wear the most, is being a breast cancer surgeon. During COVID-19, I continued to see new cancers through. We felt in surgical oncology that our volumes were low enough that we were safe to bring patients in because clinical exam was a large portion of how we were deciding the urgency of whether or not we needed to move forward with surgery. This meant that we were maybe having 4 to 5 patients in our clinic a day, if that. We continued to operate through pretty much the entire pandemic. And I'll get into that a little bit further down the road. One of the things that was really interesting and different for us is that there were 11 of us on staff that are specialized in different areas of surgery, but are all trained as general surgeons. And we ended up in an effort to offload our surgical ICU team They're the folks in our hospital that take most of the general surgery call, but they also are trained in treating patients who need acute ventilator treatment. And so in order to offload them, there were 11 of us who ended up starting to take general surgery call again. And so that was one of those times where we talk about teamwork and how important teamwork was. We all saw that the need of the community was to have these people available to take care of ventilators. And so we were more than happy to take general surgery, well, more than happy. We were willing to take general surgery call. And then additionally, I was trained to deploy to the ER should that event arise. And I think a lot of us started to train to do things that were outside of our normal scope, but things that we were comfortable with doing. My second one of the other big hats that I wear is leading the breast transdisciplinary team. This is a group that Dr. Wallace oversees, but I just take care of the smaller portion, the breast group. And during this time, I sent out a lot of emails. I think we were all sending out a lot of emails. I tried to once a week sort of gather together all of the information that was being put out by our national societies on treatment of breast cancer during COVID-19 and distribute those to the team so that we could look at them as a group and establish consensus as to what we felt was appropriate for UVM. A lot of those guidelines did talk about delaying surgical care, and I'll talk a little bit more about that in a minute. I also made the decision to cancel in our normal format our multidisciplinary clinics. Those are clinics where a patient will see medical oncology, radiation oncology, and surgical oncology in one visit. As you can imagine, that is not a socially distant situation and was going to be impossible to achieve. We switched to our remote tumor boards, and Jim set up a really neat thing with our whole network where the cancer services across the network were participating weekly in network-wide calls so that we could all be on the same page about the care that we were providing across our network. Next slide. So let's get a little bit more granular about surgery. So about mid-March, all elective cases at our hospital were put on hold. The goal of this was twofold. The first goal was to hold off on PPE. We needed to be really careful with our PPE, in particular the masks that we are, and in general, the OR is a large utilizer of PPE. The second reason was the whole concept of let's keep people who don't need to be in the hospital out of the hospital. So in starting in the middle of March, elective cases were put on hold. Cancer cases were not deemed to be elective, and we were allowed to operate for quite a bit longer. And as a team, we sat down towards the end of March when things were ramping up and things were getting a little more concerning. And we looked at all of the cases that we had already seen and came up with a plan to try to get those patients operated within the next week. And so, for example, Dr. Harlow is my partner. He also treats breast cancer, and with consent from his patients, I had 2 full days of OR time that I took his patients and operated on them with the goal of trying to get their cases done quickly and not have a delay that could be avoided. And so in the last 15, or I guess it was the last 12 working days in the operating room, I operated 9 of those 12 days. And it's kind of hard to see on these screens, but these little whiteboards are the pre-op area. And in the pre-op area on a normal, Wednesday at noon, every single piece of that whiteboard is filled with a different doctor. And what you're going to see on those 2 days was that my name is the only name up there. And that just highlights that they prioritized cancer, and that there were entire days where the cancer surgeons were the only people other than like an appendix in the operating room. It was a little eerie, I won't lie, to be in the OR at this time, because as you can see, this hallway is usually packed full of people. It's pretty vibrant and kind of fun. And it was completely empty. It was very, very eerie. So at the same time that we were banding together and coming up with how we were going to get the patients operated that we had seen within the last month, we were still seeing new cancer patients, and it was becoming clearer and clearer that we would not be able to operate on these patients in the same fashion that we normally did. And so what we ended up doing was handing them off to our medical oncology colleagues, and for breast care and for some of the GYN diseases as well, patients were placed on endocrine therapy, and that can provide a temporizing layer so that we can delay this safely and still do good treatment. This isn't crazy. This isn't something that we only do during COVID-19. I'll tell you, the other time that I do this a lot is it seems like people tend to get breast cancer right before they're going on their dream vacation, the vacation of a lifetime, where they've been waiting and they're going to France for 2 months. And they say, is there any way? And so there are other situations where we do this. So this wasn't something crazy. And patients were actually really respectful and very much supportive of these plans. Nobody wanted to be in the hospital. So those cases were put on hold and we initiated medical therapy. Next slide. Jacqueline, can you move? There you go. So this is really, really small writing. Those are my favorite kinds of slides. But this goes from the week of 3/16. This is the week when the governor started shutting down our state, and it goes all the way till last week. And this is the OR case volume as we go through COVID, and it's kind of interesting to look at. The main operating room, the one all the way to the right, is the one where most of the cancer cases are done, and we operate in all cases, about 55 cases a day in the main OR. And what you can see is as you go down through the pandemic and things are worsening, we go down to, maybe 10 cases a day or 14 cases a day during the height of it. And then things start to slowly ramp up. And what you can see is that by last week, we were back to a volume that really approaches what our normal volume looks like. But you can see that there was a huge dip, and that's reflected in about, I think, somewhere around 2,500 elective surgical cases that were held, and now we're starting to filter back into our operating rooms. Next slide. So what is it like to operate in the time of COVID-19? So interestingly, thankfully, our operating rooms only mandated use of N95 masks for a couple of days. I had the misfortune, because I was one of the only people operating during that time of operating like this, and I really feel for my colleagues in the areas that were high volume, because what you have to do when you're in the operating room is you have to wear your regular surgical mask, because that's actually the sterile mask that's keeping the patient safe. And you wear that over top of your N95. And the N95s on their own are quite a task to breathe in for anyone who's ever, the ones you get at Lowe's are pretty awful, but the ones at the hospital are really well fitting to your face, and nothing is getting through them, which is reassuring. But sometimes it feels like not even air is getting through them. But in addition to just that one, we also have the surgical mask on top of it. So you can see what it does to your face. It's really uncomfortable, but certainly it felt good to have the safety net of the masks. So I said that we only did that for a couple of days. So what are we doing now? Next slide. So now what we're doing is, because testing has become incredibly much more available and prevalent, we are testing all of our patients for COVID pre-op. If you are coming in for an elective surgery and you are unwilling to get the COVID test, you are not going to get your surgery. And if you do test positive, you will be delayed unless it's absolutely necessary. Obviously, if you come in with a ruptured appendix, we have the capacity to treat. It's just that if you're positive and we can delay until you're healthy again, we're going to delay. As I said before, the ORs are running at almost capacity. Aerosolizing procedures, so what does that mean? So when we have somebody who's coughing or somebody who's expelling a lot of air, we call that an aerosolizing event, right? So small bits of their spit and can get into the room. One of the biggest aerosolizing procedures that we run into in medicine is when someone's being intubated. That can actually, intubation is where we place a tube to breathe for you during surgery. And when we're doing that, sometimes patients will cough. And so to have an excess of caution, what we're now doing in the operating room is during intubation, only anesthesia is allowed in the room. So the anesthesiologist, and if they have somebody that's helping them, and they are in full PPE as if every single patient has COVID-19. The rest of us wait outside the room. I have a great video game that I play on my phone, and it's called Eggs Incorporated if you want. And I sit and play with my chicken game and wait, and it's the longest 10 minutes in the world. And in that 10 minutes of time, the thought is that they've done some look and see that the operating room clears its air out twice in that time. And so it's felt at that time that it's safe for us to enter just wearing normal surgical masks. And we do that again at the back end. And we're slowly moving upwards. I will also say that the cancer service line was the first group that was allowed back into the operating room. And so we were the last ones out and the first ones in. And so we have not seen the backlog of cases that the other services have. And that's been very nice. And I will also say that even though the operating rooms are pretty full and people are trying to get a lot of stuff done, I can still get my cases on without any delays. And in fact, was able even this week to get someone on for next Monday, which is pretty impressive. So it's clear that UVM is prioritizing the care of cancer patients. And that's all I have. Bye, Mom.
All right. Thanks, Michelle. Thanks to all the panelists. And we do have not quite 10 minutes to get through these questions. And I appreciate the questions that we got during the presentations. Of these, and I think all the panelists can see them, but the second one I think might be important to address to the people that, to the person that specifically asked the question. And I think maybe Tim and Diego can take this on. So people with active cancer with COVID-19 are 5 times likely to die within the first month. Can you guys relate that specifically to different types of malignancies and what their treatments might be, and how a given patient with cancer how concerned should they be right now?
Do you want me to start, Diego?
Yeah, sure.
Sure. So we are still learning more about this one. We know that immune compromise and cancer themselves are risk factors. And so it makes sense to me to think about which cancers might be more likely to cause an immune compromise. If I've had a melanoma resected completely recently and I haven't received treatment beyond that resection, I think I'm in a different situation from somebody who has had years and years of cytotoxic chemotherapy for a blood malignancy. I think the other way to think of this is not only the kind of cancer, but also how much the cancer itself can be a problem, and so how beneficial it can be for the treatment to bringing you back to health. And so maybe that's a place to start, and I can pass to Diego, who is more of an expert in the field.
Yeah, so the short answer is that it depends on the specific disease, unfortunately, because what we call cancer includes a very wide variety of conditions. And this, unfortunately, there's not a lot of granular data. Most of the series that have been published kind of put all of them together or differentiate between those who have a solid tumor, lung, breast, colon, versus a blood cancer, leukemias, lymphomas, myeloma. So overall, though, we do have a little bit more data now, especially with the last paper that it was mentioned before out of Lancet, that the initial concern of worse outcomes in patients with cancer may not necessarily be because of the diagnosis itself, but when they actually control for different factors, they found that increased mortality was in older patients, men, those patients with high blood pressure, diabetes, cardiovascular disease, a lot of other comorbidities. So they had a cancer diagnosis, but they also had all those other things that may very well have driven most of the risk. To address the specific question about hematology in general, because your immune system is part of your blood system, they are, and it seems to be that the preliminary data, it does show that hematologic malignancies may be at slightly higher risk compared to solid tumors. However, again, with hematologic malignancies, the data coming out of, or that, you know, the reports that mentioned that ended up in those conclusions, they're taking high-risk leukemia patients who are admitted in the hospital with a ton of medical complications, undergoing chemotherapy. So there's a lot of more indolent blood conditions that sometimes we just follow over time and we don't necessarily treat. And so as much as we know that they may have a compromised immune system, which is true for any virus, we don't have, as of now, any evidence that they do worse if they contract COVID-19.
Great, thanks. I think maybe we'll go to the first question, which is kind of an extension. Now, for people that have recovered from therapy, and this is a question I actually get quite frequently now, we know that after radiation therapy, for example, there are some long-term effects post-therapy. So the question is, this is a patient who's now 8 months following surgery. They've had surgery and radiation, feels strong and healthy. Other people say they're at a greater risk of COVID because they're immunocompromised. And the question is, are they? And I think probably we should make sure to cover all of our bases. Michelle, what's your understanding of the potential risk, or Tim or anybody, of increased or decreased immune function in the setting of surgery? Are people at more risk in the immediate postoperative setting?
But it's certainly not at 8 months. You know, I wouldn't say so. I think that people potentially are a little bit more run down in the first couple of weeks after surgery, depending on what type of surgery, but I don't know of any, I personally don't, and I wonder if Tim does know of any data that says that someone's immunocompromised as a result of surgery. I don't believe that that's the case.
I agree, Michelle.
Okay. And then we know in radiation therapy, because we used to do this routinely, we would do blood counts every single week for weeks and weeks while people got treatment. And we always know that a subset of white blood cell counts go down. And these are white blood cells that are, we know, help fight viruses, but we've really not seen a correlation between that laboratory finding and a significant increased risk of infection. So again, Tim, I'll defer to you if you have any other thoughts about that, but that's how I've been answering.
Totally agree.
We've got a couple minutes left. A specific question came to me about how do we manage patients in our department who can't wear masks. So there are patients who wear immobilization devices on their face. They cannot wear a standard mask, cloth mask or otherwise. How do we manage that risk? And it's a couple of things, and it's related to how do we minimize risk all the time. We minimize the time that we have to be with the patient if we can do that safely. Distance, we try to maintain distance as best we can, but we need to be literally in that patient's face for a period of time. So our staff are wearing shields in addition to face masks. And we're just in the process of trying to identify a population of our patients who might be best if we test them routinely for COVID to see if maybe they're asymptomatic carriers as well. And that it's a very dynamic time to try to figure that out in our field if that's something that's appropriate. But that might be a population that we will think about moving forward.
And Jim, just to clarify, those are patients who are actually in the room getting radiation therapy. It's not like these are folks that aren't wearing masks coming into the hospital. This is while they're getting their therapy. That may have been confusing.
Okay, yeah, thanks for the clarification. That's right. They come in, they wear their typical mask, cloth mask or other, as long as they possibly can. But during their time of treatment, they have to take that off and potentially expose our staff to that risk. So I don't know that with 2 minutes left that we probably have time to address any other questions, but I want to thank all the panelists for the time that they've taken to both prepare for this and then to be here for this today. I think all of us in the clinic side are pretty darn busy right now, and this again I want to express my sincere appreciation to them to do this, and to Tim to join our cancer team for this presentation today. Much appreciated. Just a couple of other things for follow-up. Everybody that has participated and been watching this today will get a follow-up email and to learn more about future sessions that we will be handling, as well as our planned conference, more details to follow in early October. And I'd like to thank the team, the audiovisual team from the College of Medicine, for helping us do this. Is something that we're still learning, but I hope that we did a reasonably good job informing the people who joined us today, and did it as seamlessly as we could. So once again, thanks to you all. Thanks to the team, thanks to the panelists, and thanks to the people who spend your time with us today. Thanks very much. Bye.